Welcome back, ladies and gentlemen, to another episode of Med School Mondays with Promo, and of course, I'm your host, Promo. So what are we going to do today? We're going to talk about what happens when we have too much parathyroid hormone, and that is referred to as hyperparathyroidism. In case you missed last week's lecture on the parathyroid hormone, we discussed both the regulation as well as the function of parathyroid hormone. Click on the links below and it'll take you back to the previous lecture. Now, before we get right into today's topic, I want to remind you, of course, there's 4 parathyroid glands. They have chief cells in there which actually produce and secrete the parathyroid hormone. Once the parathyroid hormone is released, it looks for its receptors, binds to its receptors, and it works through the cyclic AMP signaling pathway. The net result, of course, we already remember from last week is increase in calcium levels and a decrease in phosphate. Now, in today's discussion, we're going to talk about, well, what happens when we have too much parathyroid hormone. We refer to that as hyperparathyroidism. So, of course, we're going to expect too much calcium levels. Now, before we get into the causes of too much parathyroid hormone, let's talk about, well, what happens when you have too much calcium levels. So hypercalcemia, a lot of the times your patients are going to be asymptomatic, so you're not going to really do much for these patients. But when your patients are symptomatic, they're going to come and present with lots and lots of vague complaints, different kinds of pains. So I want you first pay attention to this bone I drew over here, and I drew it brown for a reason. The condition I want to introduce to you is called osteitis fibrosa cystica. So there's cystic and hemorrhagic bone lesions caused by an increase in osteoclastic bone activity, leading to lots and lots of bone pain. The reason that this is drawn brown is representing brown fibrous tissue, so it's referred to as the brown tumor. Good. Second thing over here is the kidney. Well, specifically, I drew the nephron. So at the level of the nephron, you want to remember a couple different things. When there's too much calcium levels, it's going to cause a condition called nephrogenic diabetes insipidus. So the patient is going to present with lots of urination, referred to as polyuria. Good. Another thing it causes in kidneys, causes kidney stones. Medical terminology of kidney stones is referred to as nephrolithiasis. So the patient is going to have flank pain, pain around their lower back. The next thing what we have over here is the gut. I know it's not drawn properly, but again, that's besides the point. The gut, you want to remember 2 different things. The first thing, constipation. So the patient is going to talk about not being able to pass bowel movements normally. The second thing, what's happening in the GI tract is the pancreas. The patient has acute pancreatitis due to hypercalcemia levels. And again, when we're in the GI section, we'll talk about the many different causes of acute pancreatitis. Look over here, we have the heart drawn for a reason. At the heart, there's 2 different things going on. So hypercalcemia levels, you're going to have something called short QT syndrome. Okay? Hypercalcemia, short QT syndrome. The opposite of that is when you have too little calcium, referred to as long QT syndrome. So don't mix that up. Another reason why I drew the heart is to also remind you guys, the patient is going to present with hypertension. Very specifically, it's going to be a diastolic hypertension. Good. And finally, the last thing, I drew this cartoon guy over here, and as you can see, you see tears coming out of his eyes. The guy is very sad. When a patient has hypercalcemia, it's mimicking depression. So also look out for that in your patients. So how are you going to treat this patient? Of course, we said if it's an asymptomatic patient, you don't have to do the treatment. You're going to keep observing your patient for signs and symptoms. Tell them to come in if anything gets a little serious. But with your symptomatic patients, the first thing you want to do is IV fluids. Now, there's a reason why you give IV fluids first. Well, let me tell you this. The second thing you do is give loop diuretics. A loop diuretic is going to flush out all this volume. Also, it's a loop diuretic, so remember the mnemonic, loses calcium. An example of a loop diuretic is furosemide. So of course, if you're giving a loop diuretic, you're getting rid of lots of fluids. So that's why you replenish the fluids in the first step, IV fluids. Make sure you do not give the patient a thiazide diuretic. Why is that? Because thiazide diuretics save calcium. And the last thing we want is more calcium. So of course, give the loop diuretic, flush out the fluids, and we lose calcium with it. Great. And the third thing, of course, you can add bisphosphonates to it. That's also going to help decrease calcium levels. Perfect. Now let's move on to the causes of hyperparathyroidism. The first thing we're going to talk about is primary causes. Now you guys are experts at this already, right? You got primary causes, secondary causes. Of course, primary causes, you think what's happening at the actual gland itself. Secondary causes we'll refer to a little bit later, and we'll talk about, well, what are some things that are causing an increase in parathyroid hormone, okay? So, primary hyperparathyroidism, we got 3 different causes of primary hyperparathyroidism. The most common one is a parathyroid adenoma. 80% of those patients who present with primary hyperparathyroidism will most likely have a parathyroid adenoma. What you also want to remember, again, what we said many times, we're going to talk about it at the end of the endocrine series, we're going to talk about these MEN syndromes. This one specifically, the parathyroid adenoma, is associated with MEN, MEN syndrome type 1. Good. The treatment for it, of course, is surgery. Remove that tumor, just get rid of it, okay? The second most common cause of hyperparathyroidism is parathyroid hyperplasia. So as you can see over here, about 15 to 20% of your population who present with primary hyperparathyroidism are going to present with a parathyroid hyperplasia. What does that mean? That means that all four of these glands are hyperactive, engaging in producing and releasing too much parathyroid hormone. So remember that this one is associated with MEN syndrome type 2A. What you also want to remember is, yes, of course, you do surgery, you want to remove the glands, but you don't remove all of the glands. Preserve half of the glands. So the answer on your step 1, also your step 2, and even on your step 3 questions will be remove 3.5 glands or remove parathyroid glands altogether and preserve half of your gland. Okay, good. The third and the least common cause of primary hyperparathyroidism is a parathyroid cancer. Of course, again, do surgery, remove the cancerous tissue, okay? Your labs, of course, you got an increase in parathyroid hormone, and of course, if you have too much parathyroid hormone, that's gonna lead to too much calcium, it's gonna lead to very little phosphate. Another couple things you wanna keep in mind, you got an increase in alkaline phosphatase, ALP, and you got an increase in cyclic AMP in your urine. So next, what we got over here is secondary causes of hyperparathyroidism. We broke it down into renal disease and dietary issues. So let's talk about renal disease first because it's more of the common cause. If you guys remember last week when we introduced the parathyroid hormone, we said that the parathyroid hormone works on the nephrons. It works at the distal convoluted tubule where it reabsorbs calcium. It works at the proximal convoluted tubule where it inhibits the reabsorption of phosphate. So net result is increases calcium levels, decreases phosphate levels. Now what we're seeing over here is we got renal disease. So that means the nephrons are not working properly. So if the nephrons aren't working properly, you can expect that at the PCT, at the proximal convoluted tubule, the parathyroid hormone isn't able to inhibit the reabsorption of phosphate. So instead, phosphate levels will rise. If the patient has renal disease, you can expect at the distal convoluted tubule, the parathyroid hormone can't act over there. So instead, we can't reabsorb that calcium. Instead, we're losing it. Good. So the labs will, of course, have a high PTH like expected. It's going to be a low calcium level, and it's going to be increased phosphate level. How are you going to treat this patient? Continue investigating the patient. Investigate what is causing this renal issue. Okay? Now, some of the other causes that cause secondary hyperparathyroidism include dietary issues. So as I wrote over here, a calcium deficiency or deficiency in vitamin D, that's going to lead to hyperparathyroidism. Now, how does that work? Of course, when you have low levels of calcium, when you have low levels of vitamin D, right over here, low levels of calcium and low levels of vitamin D, that's going to stimulate the parathyroid hormone. When the parathyroid hormone is stimulated to high levels, again, it's going to lead to a decrease in phosphate levels. So that's a key difference you want to see over here. With dietary issues, you're going to get a decrease in phosphate levels. But when you have a renal issue, you're going to get an increase in phosphate levels. So definitely keep that in mind for your board exams. Don't get tricked up over there. How are you going to treat these patients? They're missing calcium, they're missing vitamin D. So of course, replace them with calcium, vitamin D. Good. And then lastly, we want to talk about some ectopic causes. You want to remember there's a parathyroid hormone related peptide that also acts like parathyroid hormone, and it's going to increase calcium levels. So where's this parathyroid hormone related peptide coming from? It's an ectopic production of this peptide hormone at the level of the lungs. When a patient has squamous cell cancer of the lungs, when the patient has renal cell cancer meaning kidney cancer, he or she is going to be producing this PTHRP, parathyroid hormone related peptide. Okay? That's it, guys. Thank you guys so much for joining me today while we discussed hyperparathyroidism. Next week, what are we going to do? We're going to talk about the opposite. What does the opposite mean? Hypoparathyroidism. If you liked the video, definitely give it a thumbs up. Share the video with your friends. Comment on the section below and subscribe to the channel. And we will see you next week on Med School Mondays with Promo.